Senate Finance Committee will come to order. Good morning, everyone. It's it's Thursday, and it is February 18th. We have Senate File 694 before us. Senator Dahms, it's the Premium Security Plan, and welcome, members. And for the record, Senator Dahms, before you start, we do have a quorum.
Thank you, Madam Chair and members. Certainly appreciate the opportunity, Madam Chair, to present Senate File 694. Just a little refresher on Senate File 694 and its predecessor files, and what this does is Senate File 694 extends the reinsurance program for one more year. So it extended through 2022. Currently, it ends at the end of 2021. The premium or the reinsurance program was put together back in 2017, and that was put together to be an answer for the issues we were having in the state with our health insurance in the individual market that were caused by the Affordable Care Act. The Affordable Care Act did have some reinsurance provisions, or what they would be similar to reinsurance at the federal level, that helped the state with some of the funding. However, that sunsetted and was stopped at the end of 2016. So when the rates came out in the fall of 2016, we saw rates go up anywhere up to the highest increase of probably about 49%. So what happened is it basically pretty much really destroyed the individual market. So in 2017, we came up with a reinsurance program, and what that program did is it offered an opportunity for the risks to be offset with reinsurance. And so you would start at $50,000, and then at the $250,000 would go back into the hands of the insurance company, and in between the 50 and the 250, the insurance company would pay 20% and the state would pay 80%. To start this program, we worked with the Commerce Committee, the Health and Human Services, not committee, but agencies, Health and Human Service Agency, along with the governor. And Governor Dayton saw the numbers that the Commerce Department were showing, and they were estimating in their analysis that it would cost about $271 million a year to run the reinsurance program. So Governor Dayton required that we put $542 million into a premium security fund in order to make sure that we could cover the first 2 years, which is what we passed the first bill for. Fortunately, those numbers were very, very far off, and so today we still have money in the premium security account from that original investment. And so after we pay the 2021 cost, we should have approximately $118 million left in that fund. And then also we get the funding from the 1332 waiver from the federal, and that's used this past year, I believe it was $86 million. And so that will be somewhere in that neighborhood. Typically it goes up a little bit, but they are using the numbers in the fiscal note from that. So that's where it's at today. We will have $118 million in the premium security plan, and then we will be counting on, probably we're using $86 million, I believe it is. And so we come up with a negative figure of about $5.9 million for the year of 2022. Keep in mind that $5 million does not include any potential increase in the 1332 waiver, does not include the interest that will be accrued on the money for that year, so it could be less than that. There is, the Commerce Department did mention in the hearing yesterday, I believe it was, yes, it was yesterday, that it appears that the 2021 hard numbers may be about $2 million higher than what was originally projected, so that it could be up to $7.9 million before we take the subtract the interest and things like that. So that's where we're at today. And with that said, Madam Chair, did you want to have the fiscal note gone over by your analyst?
Thank you, thank you, Senator Dahms. I certainly will. And with us, we have Mr. Dennis Albrecht. Good morning, Mr. Albrecht.
Morning, Madam Chair. Mr. Moon is here as well. He's going to start by going over the Commerce Department part of the fiscal note.
Good morning, Mr. Mum.
Morning, Madam Chair, members. I'll just, Senator Dahms covered it pretty well, but I'll go over the commerce costs in the fiscal note. So if you're looking at the first page, the first number you see in the table there, $123,823,000 for the Commerce Department. That's the focus of what I'll go over. And if you flip to page 6, there's a table that summarizes this very well. It's the second table on the page shown under the heading expenditure and/or revenue formula. And basically, this just shows that at the end of fiscal year 22, there will be a balance in the premium security plan account of roughly 118.5 million. That's when the program is scheduled to end under current law. So extending it would carry that balance forward into fiscal year 23. And then the federal revenue that would be assumed under the current waiver is roughly $86 million. So you add those two numbers together and you get a total amount in the reinsurance account of $204.492 million. The Department of Commerce estimates that the payments will increase by 10%, which arrives at $209.887 million. And the difference between those two is the negative $5.395 million that's shown on the last line. 2 points to note, one of which is covered in the fiscal note, is that the department is due an estimate on the federal revenue amount any day. They actually had expected to receive it by now. So that number could change. And also I can't remember the second point I'd planned to make, but
Mr. Mum, was it on the interest?
The most important.
Mr. Mum, was it about the interest?
It was not, but it was a minor detail, so I'll forgo that and hand it over to Dennis.
Thank you, Mr. Mum. And we are expected to get at least the 86 million, is that correct? 86.064, any minute?
Madam Chair, I am not sure if that amount could be adjusted upward or downward. I would have to check with the Department of Commerce on that.
Okay, thank you. Senator Benson, before we go to Mr. Albrecht.
Thank you, Madam Chair. And our first year, the number that we're talking about was, I think, 139 million. I'm trying to do this off the top of my head. And then it was about 86 and then 85. So this adjusts every year based on, I think it's the second lowest or the second most popular silver plan. And so 86 might be on the low side, but we should have had this in October, is my understanding. Are we going to talk about the BHP letter as well? Because I think that will have an important impact as we go forward. Maybe Mr. Albrecht will cover that.
Okay, thank you, Senator Benson. Mr. Albrecht.
Madam Chair and members, I'm going to talk mostly based on the information on page 3. And then if there are questions, we can go further into the fiscal note and talk about the details. But this table describes at a very high level the interactions going on both at Commerce that Mr. Moon just described, and then at Human Services and MNsure. And so I'm talking about the section on page 3 that's labeled number 1, expenditures, absorbed costs, and transfers out. And the first thing I want to talk about is the effect in the Healthcare Access Fund, the $55.323 million and the $58.35 million. That is attributable to a revenue loss in the Healthcare Access Fund that results from continuing the reinsurance program, because the reinsurance program reduces premiums. And Minnesota's basic health plan, Minnesota Care, is funded under the Affordable Care Act, which provides to the state 95% of the amount a person would have gotten had they purchased their insurance through the health insurance exchange. So when premiums go down, likely subsidies go down, and 95% of that smaller amount is obviously a lesser amount than is currently projected. And that's what these amounts represent. For the general fund, that amount, $113.673 million in fiscal year 2024, is the total of those two numbers that are affecting the Healthcare Access Fund. And the reason for that is that in the November forecast currently, the projected balance in the Healthcare Access Fund at the end of fiscal year 2024 is 0. And also under current law, there is a transfer of a little over $121 million currently from the Healthcare Access Fund to the general fund that depends on there being a balance in the Healthcare Access Fund. So this revenue loss to the Healthcare Access Fund would otherwise lead to a negative balance in the fund. And so what happens with this fiscal note is that the value of that transfer from the Healthcare Access Fund to the general fund is reduced from 121 million to, I think, a little over 7 million. Any questions about that before I go on?
Members, any questions for Mr. Albrecht? Mr. Albrecht, when did that 121 or 122 million from the Healthcare Access Fund to the general fund, when did that, it goes back to FY20, but can you give us a historical reference on that again, if you don't mind?
Sure. Madam Chair, that provision was established first in 2003 when the legislature expanded the provider tax to apply to the MA revenue that providers receive. And at the same time, so that revenue went into the Healthcare Access Fund. And at the same time, the legislature enacted a rate increase to reimburse providers for their higher costs by having to pay the provider tax. And the cost of that rate increase was paid out of the general fund. So this was an effort to reimburse the general fund for the cost of that rate increase.
Okay, thank you.
If you want more history, there is a little bit more, but eventually in I think 2015 or 16, it ended up at this amount of $122 million a year, and that's where it has stayed since then.
Okay, thank you. Senator Ingebrigtsen.
Thank you, Madam Chair, and Mr. Albright. I think you might have re-explained, or maybe I didn't catch it again. In 2024, you're saying the Healthcare Access Fund will be a balance of 0. Can you explain real quickly how that happens?
Mr. Albrecht.
How the balance gets to 0?
Yes, please.
Senator Ingebrigtsen? Based on the budget that was established in 2019, and then subsequent changes since the forecast. So the last forecast reflected some reduction in revenue than compared to what was known in the 2019 session and the forecast after it because of reduced services that I think everyone is familiar with because of COVID. So there's that. There's a little bit higher participation in Minnesota Care, also related to the pandemic. And then, like I said, there's this $122 million transfer that is sort of allows the fund to become zero by adjusting it. If you have this, the statement does show a structural imbalance in fiscal year 2025. So there is a negative balance at the end of fiscal year 2025 of a little over $15 million. So the fact that it becomes absolute zero is related to the availability of that transfer from the Healthcare Access Fund to the general fund that depends on a balance being there. So once that transfer gets to zero, then the projected balance goes negative.
So,
Senator Ingebrigtsen.
Madam Chair, a real quick follow-up then. So you, Mr. Albright, you talked about the pandemic making a difference, and I don't think anybody will dispute that. Has that been figured in? And Madam Chair, maybe I should already know this, but the dollars that came from the feds, was it ever computed into the loss here for this particular fund? I mean, is that something that can be done, or was that decided not to? Can somebody explain that a little bit for me? Maybe it doesn't qualify either. I don't know.
Mr. Albright.
Madam Chair and Senator Ingebrigtsen, I believe there were small amounts attributable at some point in all of those allocations from state agencies to the Healthcare Act, but I can't be certain about that. There were no large amounts going into or out of the Healthcare Access Fund as a result of all that activity.
Okay, Madam Chair, real quick.
Senator
So there was
Ingebrigtsen?
follow-up. There wasn't. So there, to the best of your knowledge, then, Mr. Albright, that the money that we can prove, or that you can prove, that was lost because of because of COVID, has not been replaced into this fund.
Madam Chair, Senator Ingebrigtsen, that I can say no, for sure.
Okay.
Senator Benson, to this point.
Thank you, Madam Chair and Senator Ingebrigtsen. The Healthcare Access Fund is going to zero because we have used it as a way to get out of Dodge on at least a couple occasions. I'm going to take this moment, even though it's not to this point, that the enhanced FMAP could be put into the Healthcare Access Fund and resolve this problem. But that's probably not going to happen before the February forecast. It'd be $300 million.
Thank you, Senator Benson. I thought it was 350.
Madam Chair, 6 months at approximately $50 million. That's back of the envelope, but it would be close.
Okay, perfect. Well, and we do have another federal stimulus coming, sounds like shortly also, so that will do a number on all of our targets. And now we have Senator Franzen.
Thank you, Madam Chair, and thank you for going over the fiscal note. But this seems to be a problem that was way before COVID in terms of the balance and the Healthcare Access Fund, and Dennis can or Senator Benson can affirm that. So we've essentially drained the fund to balance our budget. We've already mentioned, Dennis already mentioned, Mr. Albright already mentioned that we would have a structural balance starting, I believe, 2025, if I wrote my notes correctly, shortly. So this bill would actually exacerbate the deficit that we would have in this fund versus using what's currently there in the premium security account to replenish our general fund or our healthcare access fund. It just seems to me that this is spending more money than we have, and we should focus on having a structural balance in our budget versus keep using the healthcare access fund as a slush fund, which we I'll say all of us have used it as a slush fund if we go back to historical perspectives that Mr. Albrecht can probably fill us in even before my time. But in my time in the Health and Human Services Committee, this fund has been used for several purposes, and it's also been used for purposes other than those that it was designed to do, including the reinsurance program, in my opinion. That's why I wasn't able to support it originally, because we're just shifting money around, and right now we have a deficit. We don't have the February forecast to really tell us how this is going to pan out. So my point is this bill is premature without complete information, and it actually, if we pass it today, it would exacerbate the problem that we have with the negative balance on the healthcare access fund, and already pointing us to a structural deficit in that fund. So I have really big concerns of why we have to move this. I expressed that in Commerce, and I know that plans need to set their rates, but we can't help them if we don't even know how our fiscal house looks before we help others. And I know that COVID has been bringing a lot of federal transfers, so that in effect is needed and welcome. But to continue to subsidize the individual market at a point that it's past its due course, 4 years to claim that it still needs support from the state, from the government to subsidize it when we have other priorities, I think it's really concerning to me and to taxpayers that we want to reopen schools, we want to do all these things, and we want to put some more resources in healthcare, and people need that direct access. And I'm thankful for the federal partnership with vaccines and reimbursements and so forth, and our relief fund. But I just question why this is good fiscal prudent policy. And I would ask Mr. Albrecht if he can confirm that this would indeed exacerbate the problem of our healthcare access fund and to the tune of 121 million or more. There's a lot of transfers going back and forth, and it's hard to even people who have been in these committees to follow. So I think the public will have a hard time following that too. But at the end of the day, we all know what a deficit is. And can we pinpoint what that would look like with this bill? Mr. Albrecht, if you can help us with that.
Mr. Albrecht.
Madam Chair and Senator Franson, the only part of this activity that is attributable to Senate File 694 is the reduction in revenue in the Healthcare Access Fund, the $55.323 million and the $58.35 million. The interaction between the Healthcare Access Fund and the General Fund complicates the budget for this proposal because of unrelated statutory provisions. And so it takes a long time to explain it from my perspective, and it adds some confusion to sort of looking at what is the overall cost of this proposal and what does it do to the state's budget. But the activity in the Department of Commerce section that Mr. Moom described is the direct costs attributable to the reinsurance proposal, the $209 million worth of payments. The effect in the Healthcare Access Fund, as I explained, is, it results from the fact that the reinsurance payments cause the premiums that are paid in the market to be lower, and the funding for the BHP is based on premiums.
Madam Chair.
Yes, Senator Franzen.
I appreciate that. I guess on a global scale and just seeing it from afar, but for the balance that we have right now that wasn't used for this program, we wouldn't be doing this because we wouldn't have any money, right? So I question the timing, I question the need, I question the priority. of using $121 million of around there, roughly, to a program that arguably doesn't need to be funded as a priority for our state right now. I really do think we need to look really closely at whether those monies could be used for other purposes during a global pandemic that's affected the entire economy, whether this sector of the economy needs a government handout, quite frankly. Thank you.
Thank you, Senator Franzen. Senator Dahms.
Well, thank you, Madam Chair and members. Just a couple of things I'd like to comment on. First, just talk about a letter that the temporary Commissioner Grace Arnold from Commerce and Commissioner Harpstead have sent to the CMS requesting that there be a review of the BHP funding for part of the waiver back in 2017. In 2017, that waiver included a couple of things, excuse me. We received part of the waiver, but we did not receive the BHP part. So they've sent a letter requesting that that be relooked at. They felt it was in error back in 2017. We felt that way all along. What they've done is they have requested that that be looked at. Back in 2017, CMS did authorize both pieces to the waiver, but then the Treasury Department chose to get involved and decided that the BHP part was not eligible, and that was to the tune of $55 million roughly a year. So the other part I want to point out is that the $113.67 million that we're seeing on the sheet here on the fiscal note, what that amounts to is that's the estimated amount of money that the state would lose because they had a program that reduced premiums, and you're paid on your program by the amount of premium you generate, and this reduces the premium, and when you reduce the premium, you're going to get less money. Unfortunately, that's the way they do it, but that is the way that they do it. That $113 million assumes, and this is a big assumption, in this fiscal note assumes that if there is no reinsurance program, that we'll have 100% sign up. Now, I think reality, excuse me, folks. I think reality would say that's not going to happen. When you raise premium by 20 to 25%, which will happen, you're not going to have 100% people sign up. If we have lost sight of what we're going to have, let's go back and look at the 2017 and look what happened that year. It basically just about destroyed the individual market. Like I said earlier, we had 49%, up to 49% increases. We had several companies that no longer would participate. We had counties through the state that did not have an insurance provider. We had very few plans with the providers we had. In 2021, every county has at least 2 providers. Some have up to 5 providers, and we have over 200 plans optional within every county. And we're looking at a very small rate increase. The rate increases in 2021 for the individual market were between 0.6% and up to about 4.7%. So this truly does work. It's not a question if it works, it's a question, do we want to repeat what happened in 2017? And apparently we have some people who would like to see that happen. I, for one, am not one of those. We have an issue in the individual marketplace. We have a situation to where we're just coming through the COVID. We have a lot of independent businesses. We have a lot of agriculturalists. We have a lot of farmers that are struggling out there. And now we're going to come along and tell them that we're going to pull the program out and we're going to raise their premiums 20 to 25%. Who are we kidding? This is not the thing to be doing at this point in the economy. So with that said, there's questions why it's important to get this done. Well, I think there's several things we need to take a look at as to why this is important to move on this and get this done. Number one is the fact that we do need to get information to the insurance industry so they know how to start planning for year 2022. Now, some people might question why they need this information that quick. Well, it's because they want to have their actuarialists have accurate information so that they can go ahead and make the proper plans for their premiums and the programs that they're going to present. Another thing that it's important that we do this is we're in a situation right now to where many of our committees have not even received their agency bills yet. We have a lot of work to be done once we get the February forecast on the budget. So this is an item that we can move forward on now. And yes, we're making some assumptions, but let me tell you, we'll be making assumptions 2 months from now. So the point is, this is something that we can do now. We can move this through now, get it approved and move on, get the information to the insurance companies, and have a good program for 2022, or we can choose not to do that and step back and watch 2017 repeat itself. Thank you, Madam Chair and members.
Thank you, Senator Dahms. Senator Kiffmeyer.
Sorry, Madam Chair, I just was flipping between the two. That's okay. So Senator Dahms, probably one of the biggest problems I see in this kind of debate, and it's great we talk about numbers. Numbers are important. They have to balance. We get that. But I think the biggest thing is the reason for this, like you mentioned, Senator Dahms, was sadly what happened to Minnesotans before we had this premium security plan and the tragedies that were going on out there. And this gave them a lifeline, a very good one. But these are high-risk Minnesotans. These are a pool of people who, without this kind of support, go bankrupt and end up usually on a government program. And these are high-risk people. They want to take care of themselves and they need some support. But that's the essence of this. So, Senator Dahms, the question I have for you, though, and some of the folks have talked about, well, this is just kind of a freebie to the insurance companies. And so I think it's really important that we take a look here, and the question I have for you is, what happens to the money that goes from Minnesota into, and my understanding it's a pass-through, it's for specific billing, this doesn't go to their bottom line, so Senator Dahms, could you just affirm and comment on what this means to insurance companies? So we just kind of clear that misperception up.
Thank you, Madam Chair, and Senator Kiffmeyer, thank you for the question. These dollars go to offset the claims between 50, the entrance point is 50,000, and the exit is 250,000. So when you get insureds that fall into that area, then reinsurance steps in and pays 80%. And reinsurance would be the dollars that are in the program to offset those dollars. So then that goes to the insurance companies to offset their claims. Now, some people could say, well, it goes to the bottom line, whatever. It is part of the cost of doing business, and that money offsets that cost when it comes to claims. Now, we also hear people say, well, they're just putting that in their back pocket. Well, you know, if you understand insurance in the state of Minnesota, you'll know that that's just definitely not true, because we do have profit guidelines. You can only make a certain percent of income in Minnesota before you have to give those premiums back to the insureds. So it's good rhetoric to say, well, it just goes to the bottom line of the insurance companies. It's good rhetoric, sounds good, but reality is that that's not the case. That's not what's happening. And if you really take a look, it should become pretty apparent, because if we look at 2017 with rates as high as 49% increase, and now we look at today with the highest increase being about 4.7%, it shows that those dollars are doing what they were designed to do. They were designed to help offset the cost of the claims, which drives down your cost, which drives down your premiums. So it's worked just as was designed. The problem is it's fairly simple. And sometimes around here we don't like simplicity, because it makes too much sense and it works too well. This program is working very well, and there's a lot of question about, well, this was supposed to be a bridge program, this, that, and the next thing. And when we first took a look at this, it was talked about trying to help us get through to see what the next stage was going to be. Reality is that other than going to a single-payer program, where we'll put a majority of our hospitals in rural Minnesota out of business because single-payer will pay Medicaid rates, and rural hospitals cannot survive on Medicare rates. And we're not fortunate as some of the hospitals in the metro area that get assistance because they take so many Medicaid patients. We don't have that luxury in rural Minnesota. So we need to have a program that pays these hospitals for the work they're doing. And this insurance pays considerably higher return on a dollar than what Medicaid does. So there's various reasons why this is working, and it's working well.
Madam Chair, if I could just
Senator
follow.
Kiffmeyer.
Thank you, Senator Dahms. That was a really good explanation. I know how well you are versed in commerce issues and insurance issues, and that shows in the way this has been structured and how well it works, so appreciate that. The other thing, though, is that Minnesota had a program like this before Obamacare was passed. Minnesota had this and a long time, and it was very successful. And so this is not like really a new thing. It was actually finally figuring out how to help it and also responds to a crisis. My question for you, though, Senator Dahms, also is, what about other states? Is Minnesota alone in this? Are there other states? Could you just address maybe financially how this works in other states?
Thank you, Madam Chair, and Senator Kiffmeyer, thank you for the question. I believe it's 14 other states have adopted our program or very similar programs to it, and it is proven to work very well. We have had requests for information from some of the federal senators wanting to know how the program works. This has been looked at that level. Like I say, I think there's 14 states that currently use this now. I do appreciate your comments on prior to Affordable Care Act and where we're at. We had a Minnesota Comprehensive Health Program, and that program worked very well. Now, yes, it was a program to where if you had conditions that were not acceptable by an insurance company, you could go into that program. And the premium was higher. It was up to a maximum of a 25% surcharge. And so that program went by the wayside. Minnesota had some of the best health care programs in the nation prior to the Affordable Care Act. Many states did not have those, so it was felt the Affordable Care Act would help those. In Minnesota, it harmed us. It took away the really good programs we had, brought in the Affordable Care Act, and then we ended up with 2017 because of it. We can't go back to that because the structure doesn't allow this. So that's what's prompted the program we have now. And right now, with that program, we have some of the lowest rates in the nation for the individual health care plan. And to me, that says a lot. And it shows how adoptable Minnesota is and how important health care is to the citizens of Minnesota and to the legislative body, that we have been able to take that batch of bad fruit and turn it into something that is working very well. It puts us back at the top of the level when it comes nationwide for insurance, where we were prior to the Affordable Care Act. So it does say we're adoptable. I think we did adopt, and I think that thanks to this program, that had a lot to do to that adoptability.
Thank you, Madam Chair. Thank you, Senator Dahms.
Senator Benson, followed by Senator Marty and Senator Johnson.
Thank you, Madam Chair. And I just wanted to, we've been talking about subsidizing a particular part of the market. MA is a huge subsidy to the people who are recipients of medical assistance, and we've decided to support that population. Minnesota Care is heavily subsidized, and we've decided to support that population. Every single employer gets to take their health care expenses for their employees and deal with it pre-tax. It is treated like compensation. So if we want to talk about stopping subsidies, I think we have to have a much broader conversation. This is the only part of the market where the government doesn't take some point and say there's value here. So this is our way of saying there's value in having an individual insurance market, in having entrepreneurs being able to not be employed by a large employer to get their health care, but instead have reasonable access to at least some healthcare choice in the state of Minnesota. And I know a lot of people have struggled to pay premiums and deductibles, but we need to keep something in existence for that part of the population. So if we want to talk about eliminating subsidies, let's broaden the conversation to include everybody who gets some sort of support for their health care.
Thank you, Senator Benson. Senator Marty.
Thank you, Madam Chair. And I did have some questions for Dennis, but before that, I did want to respond, at least briefly. Senator Dahms, I strongly agree with you on the importance of simplicity, and I don't think you can argue when people here on the committee are having trouble figuring out the finances of how this impact changes the premium subsidies that people get on the exchange, when it changes how much we get through the BHP, when you talk about all the interactions. Members of this committee are going back and forth, and it's incredibly complex. You gave a great argument yourself for how screwed up the system is when you said some plans, a few years ago, some of the plans were just dropping coverage in counties. We have a terrible, what we're supposed to be doing is figure out how people get health care, not some kind of insurance that might cover them for some things. And I guess I just think that you articulated very well how screwed up the system is, not how wonderfully it's working. And then one other quick comment, and that is when you talk about rural hospitals, you have a gross misunderstanding of what some of us are proposing with what you would call a single payer plan. I've got a plan that would help rural hospitals, would help a lot, and where you get this idea that everybody's going to pay Medicare rates and not bring down anybody's costs. The one thing, if you have a single payer system, you don't have to have so many billing clerks in every rural hospital, in every hospital. And you can get fair reimbursement for people. So I can get into that longer because I think, as Senator Benson said, we ought to look at the bigger picture because what we have now is a terrible mess. But I guess going back to the complexity of this system, I'm wondering, again, I wonder if Mr. Albrecht could answer, is there a way of calculating how much we have lost in federal funds for the BHP because of this thing? Because when we're talking the cost to the taxpayers, when we're costing out the program to the state, these payments we're giving to insurance companies, and then, well, we're going to bring down the rate so and so much, and then that, as a result, changes the subsidies that are given to people in the individual market. It changes the amount that we get from the federal government from BHP. Is there a way of calculating how much we've foregone in federal BHP dollars over the last 4 years because of this?
Mr. Albrecht.
Madam Chair and Senator Marty, yes, that is possible, but I don't have that information with me right now.
Senator Marty.
Madam Chair, I would appreciate that because I think that's a key factor. It's one of the biggest costs of this program. In addition to the money we put into it, there's that additional cost. And I'll make one more comment at this point, and that is that Senator Dahms was saying we should do this now, even though we don't have the numbers from the federal government on how much we're going to be getting from them. We don't have the new revenue forecast. We don't have everything else. We got to do this now because we got to make sure that the insurance companies can plan for next year. I think 2 years ago, you didn't pass the legislation to continue this until late. And so the insurance companies came in and they calculated with and without. They could do the same thing with and without the reinsurance program, what the rates should be. They can still do that whether we act on this now. And if it's so urgent to be planning ahead, because you're right, we're going to have a real backlog here in a very short period of time because we got so much to do and things are going to be very tough to do in this remote and whatever environment we're in because of COVID. But the biggest issue that we seem to be missing is this program ends next year. And you're saying it's urgent this year. I suggest this is the 1 year it's the least important because the health plans have all had huge savings. I mean, in the Medicaid program, they're giving money back to the state because they had a lot less utilization under COVID. People weren't going to the doctor as much. So this is a year when premiums should not be jumping large. They should be going down. But what about next year? what kind of a plan is this? You're saying, well, we're going to do this, and next year, if we were to continue, we'd have to get an additional federal waiver. When are you planning to do that? You planning to wait till next year and then saying it's a crisis? That, to me, would make more sense than trying to push this thing through now, a month before you get the numbers you need to be able to make wise judgments.
Thank
So
you,
maybe
Senator.
Mr. Albrecht first.
Miss-
No, go ahead. I guess he answered most of what I had.
He did, yes. Senator Dahms.
Well, thank you, Madam Chair, and thank you for the question. A couple of things I think we need to keep in mind, Senator Marty, is first, we talk about how people not going to the doctor and stuff, and that was one of the issues that we have with the way the governor chose to shut the state down, and it did have some real issues. The other thing, remember that elective care was shut down. And so even though it's called elective care, a lot of those things will continue to be done, either have been done or will be done at a future date. So those costs will be incurred. And when they do their rating structure, current claims go into account, previous claims go into account, but future projected claims go into an account. So if you were looking for a large reduction in premiums because of the fact that the folks weren't able to go to the doctor, some chose not to, and an awful lot of this will be in the elective care and things that were put off, those dollars will still occur. Now, if somebody didn't go to the doctor on April 16th and they missed that appointment, that cost will probably not occur, because when they go in May, there won't be an April appointment. That's fully understood. But we also need to understand that somebody had elective surgery set for July, and now it happens in January, that cost incurred. So keep that in mind when we start talking about the premium structure and the way that the actuarialists work. The other thing to keep in mind when we talk about the cost to the taxpayers because of the loss of money due to the BHP waiver, keep in mind that had we not salvaged the market in 2017, there would have had to be a lot of charity care, because the dollars would have had to come from someplace. And so chances are a lot of that would have been charity care, which will also have a cost to the taxpayer. Thank you, Mr. Chair, or Madam Chair.
Madam Chair, to that point.
Yes, Senator Giffmeyer.
Thank you, Madam Chair. I'm glad you explained that, Senator Dahms, because as a former nurse myself, the realization that right now it's deferred care, which means in the average between 2020 and 2021, the amount of care is still there. Matter of fact, costs may go up next year because deferred checking on cancer, heart conditions, other diabetes, other things like this that should have happened in 2020 are probably going to get worse. Then they're going to go into 2021. So let's realize that more than COVID is happening here in regards to health this year. And so we appreciate the seriousness and doing what we need to do, but never think that just because there was less this year, it's going to come in 2021, and that's a very important fact for them to consider. Thank you, Madam Chair.
Thank you, Senator Giffmeyer.
Madam Chair, also to this point, if I may.
Yes, Senator Kent.
Thank you. I'll just be really brief. The points about deferred care are obviously accurate, but there was a comment made that our healthcare system was shut down, as if that was something that was done to our providers, particularly in the case of elective care. And it needs to be reminded that the providers needed to do that. They agreed that needed to happen because they needed to make sure that we had PPE available for our hospitals and our caregivers. And so to make that sound like that was something that they were not a part of and that they were opposed to is, I think, a distortion of what happened. And I just needed to make that clarification. Thank you.
Thank you, Senator Kent. Senator Dahms.
Well, thank you, Madam Chair, and thank you, Senator Kent, and that's a very good point. And I did not at any point indicate that the healthcare system were the folks that suggested that. I did not say that, and that is not what I construed. But thank you for bringing that up, because fortunately, with the healthcare workers that we have in Minnesota. They did a lot of super great frontline work for us, our nurses, hospitals, doctors, the whole 9 yards. They did a great job, and we need to commend them every opportunity we get. So I'm going to take this opportunity to commend those people for what they have done and the part that they played in keeping our health system functioning to the best it could be under the circumstances. Thank you, Madam Chair.
Thank you, Senator Dahms. Senator Johnson, followed by Senator Franson.
Thank you, Madam Chair. And Senator Dahms, thank you for bringing this forward. I know in my counties, accessibility to even one insurance program was hard to find. We had Kitson and Roseau County that providers weren't even able to offer a program up there until reinsurance became available, or became a program back in 2017. So I appreciate that. And it was said earlier that this program is going to exacerbate our fiscal issues in the state. And I just want to push back a little bit on that and say, well, this will be, it's not exacerbating it. We are going to, if we take this program away, it's going to, the cost, the fiscal issues are going to ride on the back of our sick and our most vulnerable. And I'm really concerned about that, and most of us should be. And so this program at least gives some security to a lot of folks and a lot of folks in my district. So I appreciate what this does. This will not compound the fiscal issues. I think this will give some security. So I just want to make that point and thank Senator Dahms for bringing this forward.
Thank you, Senator Johnson. Do you have more than one company up there?
We do now based on the reinsurance program.
Great. Thank you. Senator Franson.
Madam Chair, and I appreciate the pushing back a little on my comments earlier, but I do want to express that I've worked for a large company. I have a small business, so I purchased insurance for my employees and my business partner, and I've been in the individual market. So I understand from a purchaser and as an employer myself, the complexities of this issue and how unaffordable healthcare is for small businesses, particularly. The big companies can probably send people to the exchanges, pay the penalty, they'll be fine. Smaller businesses have a harder time with that, with those decisions, especially when they're too small to be part of a group insurance plan or a small group insurance plan. So I get that Senator Dahms is an expert in insurance, but I like to look at what's in my insurance plan. And they're very complicated, right? For every person trying to buy and purchase insurance. I received dozens of emails during the individual market crisis in my district and from other parts of the state because of serving on HHS. So I'm not coming at it in a vacuum. What I do have to say that the emails I'm getting now is that people are losing their employers. They're losing their jobs because of the pandemic, and they are losing their employer-based coverage, which is a bigger issue that we haven't addressed and reinsurance is not going to address, of how do we get people covered. Yes, they might go to the exchanges, but certainly the issue keeps exacerbating. That's a good word because it keeps growing and it keeps changing. And to use the same tools to deal with the problem that hasn't been solved, which is the affordability of healthcare overall, and the factors that go into it, the higher increases of pharmaceuticals, the complexities, everything that goes into putting a price on insurance. We need to delve into this a little deeper and to say, yes, we subsidize a lot. The government subsidizes your roads, subsidizes your water, I get that notion as well. But here we're talking about healthcare, and the government has a role to make people healthy and to deliver vaccines free of cost for COVID. And we're doing that. My point is that we do need to look at those people, coming up who are going to be left behind because they don't have a job to go to with an employer. And that's a bigger issue. People want to be able to pay a price when they go into the doctors. We don't have a price tag for services because every insurance company bills differently, reimburses differently. And if I want to pay for it with cash, I get a different price, and maybe affordable, maybe unaffordable, but that price usually is not even available. So there are bigger issues with the cost of healthcare and why the drive behind insurance companies raising their premiums. I get it. But we need to delve into the real fundamentals of why those costs are going up, not just throwing money to a problem that hasn't been solved, which is, again, why those drivers of the costs are going up. And certainly we appreciate all the players and providers and insurance companies that play in Minnesota. We need you. We don't want you to go away, but we also want to hold all of us accountable for where we're putting taxpayer dollars. But I do want to go back to Senator Dahms mentioned something about the ACA harming Minnesota. And I want to push back on that because I want to know specifically how it did. And maybe he has examples, but the one things that I do see that benefit, not just Minnesota, but people and across the country, is that now they cover. Your insurance company has to cover pre-existing conditions. Before they were able to deny it. That's why we had MSHA, and arguably why we don't need it anymore, because now they have to cover people with pre-existing conditions, which could be breast cancer, it could be asthma, it could be diabetes. And they used to be able to deny it or allowed to deny it because we didn't have a protection. The ACA changed that. We have essential health benefits that are covered that before weren't mandated, and now they are. So your basic preventive care is covered. Some companies didn't. So we have a benchmark of what those insurance products have to look like. And I argue that that is a benefit to the health of our residents in our state. And then we can keep children 25, 26 and younger in your parents' insurance, another benefit. I can go on and on. So what are the negatives other than costs? Because we're covering more, are the harms that it had to Minnesota. A lot of the ACA was modeled on things that we had already in Minnesota. So I'll push back on that. Maybe it's too wonky, but I do think that we do need to look at the cost of healthcare as we know it. And instead of just thinking of subsidizing, let's see what are the real costs of healthcare. And that's why I push really hard on healthcare transparency. So I just want to make those comments. And if Senator Dahms has any response, I appreciate it. Thank you.
Thank you, Senator Franzen. Senator Dahms.
Well, thank you, Madam Chair, and Senator Franzen, thank you for your comments. A couple of things. First of all, I think you brought up a very good point, and thank you for bringing it up because it really shows how much the reinsurance program is needed. You talk about people losing their jobs and lost their employer-funded health care. Many of those people are not going to qualify for MNsure. So now you have the individual health care plan that they can go to, and we've kept the rates down and make it more accessible to many, many more people. So I think you're in a roundabout way supporting the plan. Thank you for that. Then I would just like to say, when it comes to talking about the impact that it's had on the state of Minnesota, we had an excellent program. And to think that the Affordable Care Act replaced that program, I don't agree with that. It did not. And you can rattle off a lot of good things that you see that it did. You may be right, it brought some good things out. But let me tell you, take a look at what happened. It crushed the marketplace. The rates went sky high. And maybe to you, rates don't mean anything, but they do to the individual that has to pay these rates. It means a lot. It means a difference, as so many people like to say. Do you put food on the table or do you buy health insurance? It made a big difference. These people had the opportunity to come in and buy health insurance at a much lower rate. So what did the Affordable Care Act, how did that harm the state of Minnesota? It turned the market upside down, and in many cases it took people and put them on health insurance, but it took another group of people and took them off health insurance. There were several people that qualified to buy health insurance prior to the Affordable Care Act that no longer could afford to buy it, and they did not qualify for some of the government programs that would allow them to buy it. So we did a lot of shift there, and those are the kinds of things that I do not think were in the best interest of Minnesota. Thank you, Madam Chair.
Madam Chair, can I quickly just rattle off a couple things?
A couple things. We still have further work by Dennis Albrecht on the fiscal note, and Senator Marty would like to talk. Senator Franzen.
So to this point, I do pay individual market. I mentioned that for my employers, employees and partners. So I know how bad they are. So I do care about the money going there. And the point is that the federal government does give federal tax credits for those in the individual market. So they are being subsidized by the federal government. They are being helped. So the insurance is on top of that. So just wanted to put that out there, that they're getting helped for their premiums through the individual tax credits that you get in the marketplace if you qualify, depending on your income. Thank you.
Thank you, Senator Franzen. Senator Dames?
Thank you, Madam Chair and Senator Franzen. So you're indicating that as long as they're getting some federal support, that we should just go back and turn the market loose the way it was in 2017 and say the federal support is sufficient? Is that what I'm hearing?
Is it a rhetorical question, or would you like an answer?
I mean, let's look at those tax credits and see how they're functioning before we make the claim, or you allege that I'm making a claim. They need to be looked at, and I think that's part of this discussion.
Thank you, Senator Franzen. And Senator Marty, and then we do have some work still on this fiscal note.
Thank you, Madam Chair. And I do want to, I didn't feel I got an answer from Senator Dames earlier, but I think this whole discussion about who's got insurance, who doesn't have insurance. Look, 100% of us as Minnesotans need health care, 100%. Some of us need very little, some need a lot. But this whole concept, well, somebody's getting a little more insurance here and it's a little less affordable here and a little more affordable there, shows how screwed up the whole system is. And none of this is going to do anything to help the problems with the rural hospitals. Nothing's going to do anything to help the people who can't afford the deductibles. Nothing's going to help any of that. But my question is, given the fact that you're working in this realm where our solution to it is to subsidize insurance companies and hope they're going to bring down the rates, there's no guarantee, but hope it'll bring down the rates, even though it's taking away other funds elsewhere and adding costs there. But my question is, what are you planning to do next year? Because you're saying this is so urgent to do now, even though 2 years ago you passed near the end of session, not early in the session. What do you plan to do a year from now? Because this program ends in a year, would require federal waivers. I haven't seen any legislation introduced yet to extend it or anything else. That would take a lot more time than this bill would. So I guess that's what I'm trying to find out. You don't seem to have a plan other than, well, if we can subsidize the insurance industry for another year, that's going to take care of our problems, or at least help take care of some of them.
Senator Dames?
Well, thank you, thank you, Madam Chair and Senator Marty. I guess your question is, what are our future intentions? And at this point, I don't have any silver bullet that I can announce today that's going to solve the problems of the health industry. But certainly there's a lot of discussion, a lot of things going on, and a lot of things being talked about. And when we get ready to present those, we will do that. Thank you, Senator Marty.
Thank you, Senator Dames. I think we will turn to Mr. Albrecht to finish up the fiscal note.
Madam Chair and members, so going back to page 3 of the fiscal note, and moving on now to the MNsure section, there are 2 lines there, one for the general fund and one for the health insurance exchange fund. Let's talk about the second one. The MNsure is funded by, I think it's a 3.5% withhold from the premiums paid for plans purchased on the health insurance exchange. And because the reinsurance plan reduces premium, that reduces the revenue available to MNsure. And they make an assumption in the fiscal note that they would not be able to continue their current operations in an environment where they had less revenue. So they assume that the legislature would appropriate them from the general fund the amount of the lost revenue, and that explains the equal amounts to their revenue reductions coming out of the general fund on the line above that.
Thank you, Mr. Albrecht. Would you like to continue? Anything else?
Not unless there are any questions, Madam Chair.
I'm looking. I don't see anything. Okay. And Mr. Albrecht, we took care of the chart on Page 6. Anything else we need to review on the fiscal note?
Madam Chair, so I focused on the table that I did because it shows the overall amounts that are described in more detail in the subsequent pages. I'm happy to go into those pages and point things out to people if they have any questions, but my hope is that I did a good high-level overview of the text that is in the remaining pages of the fiscal note.
Okay, thank you. Members, are there any questions for Mr. Albrecht, Senator Dahms, Mr. Mumm, Senator Ingebrigtsen?
Thank you, Madam Chair. I'm not just going to cut to the chase here with Senator Dahms. I'm certainly not an expert or anywhere as close to it when it comes to healthcare and/or insurance. I do remember 2017 and the years thereafter, what kind of a blast we were all getting on the cost of healthcare, the cost of insurance because of the Affordable Care Act. But I keep thinking and keep hearing and keep wondering if the government, who likes to stick their nose in the business of everybody, is not working themselves here towards a single-payer healthcare plan. Government run, I might add. You run that by people on Main Street and ask them if they want their government to run their healthcare. And I would think that if anybody was to give a serious answer, they would say, I don't want them to run anything other than roads, streets, and water. So Senator Dahms, give me an idea what a single-payer system run by the federal government or the state government would look like if we don't have some other means of subsidizing or at least helping out people with insurance.
Thank you, Senator Ingebrigtsen. Senator Dahms.
Well, thank you, Madam Chair and Senator Ingebrigtsen. That's quite a loaded question, what it would look like. I guess I would not know for sure what it would look like other than it would be ran by the state. And I'm assuming that they would be receiving money out of several different pots. And I have yet to see where the state can basically run things cheaper than what individual businesses or independent businesses can. Because of competitive level, but I really wouldn't have a good answer on the actual how it would be set up and how it operate. My only experience was with Medicare in the earlier years and how that worked and didn't work. And then that kind of morphed into Medicare being turned over to the insurance companies. And today, the insurance companies have do a lot of the Medicare stuff. The state, in many cases, the federal government pays a flat fee, and the insurance companies take care of the insurance for the Medicaid recipients that sign up with them. But that would not be probably a fair comparison, but I really don't have a lot on that at this point.
Senator Dahms, Senator Benson would like a shot at this.
Senator Benson.
Thank you, Madam Chair. We're getting kind of far afield from reinsurance, but if we're going to have a conversation about government-run healthcare, it's really more of a single-payer model. The federal government, we would set a benchmark reimbursement rate, say we set Medicare rates. Most of our hospitals aren't going to do well long-term on Medicare rates because there's huge cost shifting between government payers and private payers. So if we just put in a rule that said no Minnesotan can be charged more than Medicare rate for any medical service in Minnesota, it would plummet rates. But it would also make it impossible for our hospitals' doctors to maintain the system that they have now. So that's the kind of decision we'd be looking at. And then, for the members of this body who like solving problems, imagine a hospital that decided they wanted to upgrade their maternity ward or their emergency department or their radiology department, but they couldn't make it on Medicare rates. So then they're going to come to you as the representative from that district and say, can you get us a rate add-on just for the time that we need to pay this back? And so your health committee would become a hospital funding committee or a clinic funding committee, or we need a specialty doctor and we can't afford it at current Medicare rates. All of our good doctors are going to states where they're not stuck at Medicare rates. So it's not even a matter of the bureaucrats who would be doing the paying. It's what would happen to our healthcare system if we set government benchmark rates. Now, I would love to hear from any provider who wants to live on Medicare rates, because I haven't heard any of them say they'd be satisfied with an entire system at Medicare rates. So we can continue this conversation, but it's not as simple as government programs work or they don't. My question is, do you want to be in a bonding bill paying for a new piece of radiology equipment for a rural hospital? Because that's what's going to happen, because current government programs do not pay for our healthcare system. They keep some part of it going, but the cross-subsidy is what keeps our current healthcare system going. So that's my only comment to government programs.
Thank you, Senator Benson. And
To that point,
yeah, Senator Ingebrigtsen, I think
Really quick.
we will wrap this up because unfortunately you, Senator Marty and Senator Ingebrigtsen, you are not on Senator Benson's committee. We will be, I'm sure, talking about this ongoing. But to that point, Senator Ingebrigtsen.
yeah, and that's not a question. Just thank you, Senator Benson, for bringing us back to reality of what's going to happen to our health care. And it's kind of scary when you mention that, you know, docs and medical facilities are going to be moving out of our state to some place that doesn't have that. We always take that for granted, that we can go to the doctor and everything's going to be just fine and they're going to fix it. Well, that's because we got a great system here in the state of Minnesota, and we don't want to lose that. So thank you for that description.
Yes, thank you, Senator Ingebrigtsen. And Senator Marty. And then we're going to take a vote.
Yeah, Madam Chair, I know we don't have a lot of time, but I do have to respond to a few of the, I think, outrageously misinformed statements people have made. As one who's got a bill that is called a single payer bill, it's one that's not government run, it's doctor and patient run. Decisions under our current system are often not made by doctors and their patients. They're made by insurance companies or employers or government. We want a system where decisions are made by patients and their doctors. And that's not hard to do. And what we're proposing to do is get all those middlemen out of the way. Government doesn't need to be telling people you can get this kind of surgery, but not that kind. Insurance companies shouldn't be doing that. Employers shouldn't be making decisions about that. We spend, just so you see how this current screwed up system is, we spend twice what other countries in the world spend. There are about 10 countries, 15 countries that spend more than half what we spend, but the rest spend half or less. And better health outcomes. Even before COVID and our life expectancy being cut shorter, which every country is likely to face as well. But our life expectancy is worse than other countries. Minnesota's life expectancy is worse than other countries. Our infant mortality rate's a lot worse. All of our health measures are worse. We're spending two times as much. So what I'm not looking for is a government-run one. I'm looking for a doctor and patient-run one. And what we got now is a insurance and government and employer and patient-driven healthcare system. And the patients are kind of usually falling out of place in that. So I think there were so many misinformed things there. In terms of our legislation, we would start addressing some of those rural hospital challenges. Senator Rosen knows Fairmont's been shut down and Albert Lee's been a huge cutback. That's under the current system. And that wasn't done because of the needs of people in the communities. It was made because it didn't fit in somebody's business plan. Now, I think we have to look a big picture at this, but I just couldn't let it go with some of the misinformation that's been said there. Misunderstanding, perhaps it is. But that's not, I've got a bill that you would call a single payer bill. And it's not government run, it's doctor and patient run. And it's not bad for rural hospitals. It'll give them a chance to make it. And medical decisions will be made by the needs of the community, not by the needs of somebody's business plan. With that, I understand we're voting on this. I recognize that, but this is a temporary 1 year fix, not a fix, but it's a subsidy for the insurance industry, which is then going to, we hope, bring down the premium some. but there's no plan for the long term, and this doesn't do anything to those who can't afford the co-payments or find out their dental care isn't covered or any other problems like that. So let's not suggest this is any more than a broken temporary subsidy for the insurance companies that isn't going to fix any of the problems.
Thank you, Senator Marty. Any further questions? Senator Pratt.
Thank you, Madam Chair, and not necessarily a question, but more of a comment. And I think back to 2017. Well, shoot, I think back to 2013 when I sat on the Commerce Committee and we first started talking about the impact of the ACA and taking the Minnesotans that needed the most health care that we were supporting through the MSHA program and doing away with it and putting them in the pool. And what we saw were astronomical increases in healthcare premiums. We all got the same letters and emails from our constituents that I did. Senator, my healthcare premium's going up. I'm paying more in premium and deductible than I will ever use. I will never use it, and I'm more willing to pay the penalty at the time not to take insurance than to pay these costs. And what the reinsurance program did was effectively bring back the MSHA program. It covered the cost for those high needs Minnesotans, those with pre-existing and chronic conditions that we have been covering since the 1970s. When we say that, the ACA helped Minnesota with pre-existing and chronic conditions, that's not true. We've been doing it for 40 years, going on 50 years. What we did was we brought back the subsidy, not for the insurance companies, but for the very people who needed it, for the very people who were causing the premiums to go up. We want to subsidize those premiums so that health care is affordable to those Minnesotans who need that care. And having some stability in this program is essentially vital as we go forward. And so, Senator Dahms, I thank you for bringing this bill. And we need to keep this going. And the reason reinsurance was passed late in the 2017 session was not because the House and the Senate didn't do their work. We passed it early in the session. It was because it got caught up in the end of session negotiations. We could have had this done back in April of 2017. So again, thank you, and I'll be voting yes on this bill.
Thank you, Senator Pratt. Okay, Senator Dahms, final comments.
Well, thank you, Madam Chair and members. Some good, lively discussion. Always appreciate that. With that said, Madam Chair, thank you for hearing the bill, and hopefully it will pass and we can move it to the floor.
Thank you, Senator Dahms. Okay, with that, Senator Benson moves that Senate File 694 be recommended to pass and placed on general orders. Everyone turn their video and mics on, please. All those in favor say aye.
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 All those opposed, nay.
No.
No.
The Senate file passes, the motion prevails, and thank you very much, Senator Dahms. You are on to general orders.
Thank you.
Members, we have nothing planned for next week, but please stay tuned. Bills are coming in, and our work is just starting. So February forecast comes out next Friday, and from that point on, we will be getting busy. So thank you very much. Have a wonderful weekend. Finance Committee is adjourned.